All right, guys, so we've got a relatively quick talk now, and then we're going to break for lunch. This next talk is on how to refract a patient, plain and simple. And this talk actually is applicable to the lectures we had yesterday. It's the same refraction technique we will use in our clinic for everyone, whether we're doing LASIK, presbyond, whether we're doing SMILE, whether we're doing ICL surgery, anybody. We use the same refraction technique for everyone, and you'll see why we do this. When we look at presbyond specifically, though, just to kind of just reiterate a little bit more of the presbyond story, must remember that presbyond is not there's not one isolated magical part to presbyond. It's not just all about the surgery or all about the refraction technique or whatever. It's a combination of a system. So, you know, you're going to draw patients in with marketing. You want to make sure your message is consistent. You're not doing false marketing and false advertising in terms of meeting expectations afterwards. The pre-op assessment is extensive. We look at all the various clinical parts, but we also make sure that we counsel the patients adequately. You're going to learn as we go through this afternoon's lectures that there is a recovery phase to some of the components of presbyond. Not for everyone. Some people have it's like the next morning they're perfect in terms of their vision and they're the happiest patients. But others take a little bit of time to adapt. So you need to really reiterate this preoperatively so that their expectations are met in the early postoperative period. Of course, the procedure needs to be routine, it needs to be accurate, so hence we use our nomograms, and the refraction technique also helps with that. And then, of course, postoperative management. And as I just mentioned, there is a percentage of patients, and we'll go through this afternoon, that do need to adapt to the new setup of their eyes. I mean, a lot of us drive, well, most of us drive nowadays. If you get a new car, you can drive the new car, right? You get in the car and you drive. But it feels weird. Yeah, you're turning the indicator and it's the windscreen wiper because your last car had it the other way around. But if you drive that new car for a few weeks, it feels like you've had it for years. When you change the setup of the eyes, it's not the eyes that have to adapt, it's the brain. It's the same concept. And we see that with people getting used to their varifocals when they get them for the first time. So adaptation is something you have to reinforce. Some people adapt very quickly, but some take a bit longer. And the point is, if you've done all this preoperative work, introducing all these concepts beforehand, then it's very easy because you're just reinforcing the same message. There's consistency. They don't feel that there's something not quite right. And of course, you can just give temporary glasses to people if they're struggling with certain parts of their vision, because it's not some multifocal cornea ablation, as Dan has just mentioned. And then lastly, it's quite easy to manage unhappy patients. You can enhance them. So you're not going to leave someone with long-term top-up glasses. That's very rare after presbyond. It's only really for the extremes of vision that a few percentage, it's like less than 3% of people will still be wearing glasses at a year. And that's because you can enhance them very, very simply. And the enhancements are accurate because, again, it's nothing multifocal and all that side of things. Okay. So we have all of this information in our presbyond practical guide, and that's all on your memory sticks. So you don't have to make any notes, you don't have to take photographs of the stuff, just listen, let it all sink in, and it'll all be there for you in your packaging. We are going to concentrate a lot on a new little side angle in terms of refraction technique, and we call this the binocular balance tolerance testing. And Dan is going to go through this a little bit more later on as well. This is where you set up the patient. So I'm going to just concentrate on how to do a refraction. And when I say this, it's not for glasses, it's not for contact lenses, this is for laser eye surgery. And you'll see why there's a subtle difference. Now, I love this slide because garbage in equals garbage out. I can guarantee you nobody is putting rubbish in the bin at home, literally garbage in. And then the bin man comes along and they take the garbage can and they empty it into their car because out of it comes gold bars or loads of cash. Yeah, it goes into the dump truck, right? And then off to the dump because that's rubbish. That's what we do with it. Of course, nowadays we recycle a lot of things. The point is, if you use refraction techniques which are subpar, which have a lot of variation at the end of the technique, and I'll highlight this in more detail in a few minutes, you're not going to get good accuracy in your outcomes. Okay, so we need a technique that is super robust, that has a hard endpoint, a very consistent endpoint, in order to get good, consistent results at the end. Okay. Now, just to highlight this in a couple of ways, subtle differences. This is an example of Tim's bicycle that he uses to commute to work every day. This is a great bike for commuting. It's got the stability wheels. So when he gets to the little traffic light, he doesn't have to put his feet down. And the little unicorn horn tends to keep most people away from him for obvious reasons. But you wouldn't say that this mountain bike is similar to the little unicorn bike that Tim likes to ride to work on, right? And in fact, they're used for completely different purposes. And it's quite obvious. So if you had two different refraction techniques which were completely different, you would be saying to yourself, yeah, okay, I understand there's a huge difference here. But the problem is most of the refraction techniques that we use are only subtly different. So these two bicycles, you would say, yeah, they look like road bikes and they look pretty. I'm a big cyclist fan, so sorry about this. But the truth is these two bikes, if you really know what you're looking at, are very different. The one with the little thin tires is really, really good in the mountains, super light bicycle. The other one is what we call an aero bike. It's good on the flat, super fast. If you took this one to the mountains, you'd have a hard time because it's much heavier and you get penalized with the weight. So what we're really looking for is one entity. We're looking for a gold standard to use. And I'm going to show you this technique, and we're going to explain to you why it's the gold standard. So the bottom line is different refraction techniques end up having different endpoints. So it's all about the endpoint. Are you going to get consistency to your refraction? So just take a look at these two examples. The first one, refraction technique 1, let's say it's designed to push the maximum amount of plus out of the prescription and the maximum amount of sil. It might not be comfortable wearing those glasses in a pair of glasses walking around, but that's what the technique is designed to do. You get a hard endpoint, the maximum that that patient can possibly tolerate. And you compare that with another technique, technique 2, which is the lowest amount of plus or sphere and sil that the patient can tolerate, but can still sort of get to the same level of visual acuity. So the problem we have in refractive surgery, one of the big problems is that if you work in a big practice and you've got multiple people using different refraction techniques, for example, you get a locum optometrist coming in to help you for a day, and they're using a high street refraction technique designed for glasses wear, which is comfortable, not pushing plus and not pushing the sil, and they're obtaining data for you, well, they're going to get a different endpoint which you're putting into your nomogram charts compared to the person before who was pushing high levels of plus and sphere, and sil, sorry. So you get a lot of scatter and you get more outliers in your results as a result of this. So the critical message for this talk is that in your practice, you have to have one refraction technique, and every single person has to use that refraction technique, whether they like it or not. It's not up for debate. And they have to use the same technique pre-op and post-op. Because otherwise, you're just adding more and more scatter and more outliers, again, into your nomogram results and your outcomes. It's just obvious. And secondly, the technique has to have a hard endpoint. Everyone has to be achieving the same level of refraction that the patient can possibly tolerate, for example. That means you've really squeezed out the maximum of that refraction. And all of this contributes to, again, less nomogram scatter. So Dan mentioned it before. We often presented at conferences. I was in South Africa last year, and I had a person stand up in the audience and say to me, your results are bullshit. No one gets those results. And it's a bit embarrassing to have to belittle them in front of everyone when you can explain to them 10 reasons why they're not getting as good results as we do. And a lot of it is just simple, basic stuff like this. Yeah? There's a lot of scatter within their own systems. Now, before I actually show you the technique, just to show you how effective a really, really refined manifest refraction protocol can be, in our clinic, this was years ago, Dan and I refracted the same patient along with 7 of our optometrists. And what we found, this is 1,922 eyes, we found that the mean dioptric power difference was only 0.19 diopters. So this is among 9 clinicians. They're all using the same technique, and we'll show you the technique in a minute, and it just shows you how much consistency you can get over, that's a large population of eyes. And the beauty of this study is if you compare this study to Rausch's study, which is the same person, one person, refracting the same patient multiple times, and they got 0.2 diopters of repeatability. So it shows you that if you it's a kind of an involved technique. You're going to see it in a minute, but it actually works really well to bring people to a hard endpoint. There's no ambiguity as, do you like the green or the red? No, it's always going to be green, or in that sense. Okay. And it works for all refractions. The difference in spherical equivalent was within half a diopter in 94% of people. And the difference didn't make any difference whether you were refracting a -15 or a +8. It works the same across the board. This technique can only be done with a phoropter. It can't be done with a trial frame. You'll see why in a few minutes. And secondly, you can't use an electronic phoropter. It has to be a mechanical phoropter. So you've got to go a little bit old school, but not really old school. Okay. So just a quick point before we start the refraction itself. This is basic stuff. Make sure they're correctly positioned, that there's no tilt, which could affect the axis of the sill. That's head tilt and phoropter tilt itself. Adjust the pupillary distance. Measure the back surface. It's very good to record that. And especially for the higher diopters, plus and minus. And then obviously standardized lighting. What do you use to start your refraction? You don't have to start completely from zero. Well, we normally would use either the patient's current glasses, if they're recent. You can use an autorefractor, or you can use undilated aberrometry, because the aberrometers actually generate a refraction as well. What we actually do is we record all of these. We record what they can see with their current glasses. The Wasker line is the aberrometer. This is, we now use the Osiris, but any of the aberrometers are fine. And you just round it off to the nearest 0.25, and you record their visual acuity. We then do our manifest refraction, and we also do a cycloplegic refraction. Our preference is to use the aberrometer refraction to start from. So we nowadays use the Osiris, but in the past we used to use the Wasker. So this is whole eye aberrometry refraction. So a lot of these initial screenings are done by our optometric team. What then happens is the patient meets the surgeon on a separate day, because they are dilated at their initial consultation, so we can't refract them on the same day as the optom. So they come back a second day, and they have a second refraction done by the surgeon now, and that's the refraction that's used for the treatment. The surgeon has a huge advantage over the optometrist, because when they're doing their manifest refraction, they're going to be pushing plus, as you'll see. It's one of the key features of our refraction technique. But we have their manifest refraction to start from, and we also have their cycloplegic refraction, with obviously the ciliary muscle paralyzed. So we know, for example, in a case like this, where they found on cycloplegic refraction an extra 0.50 plus, they weren't able to get that out of the refraction. But now that the surgeon understands that there's a bit more plus, they can even really push plus, really try and disaccommodate this patient. One of the key features that we have to stress is when you treat someone, you should only ever treat off your manifest refraction. Never treat off the cycloplegic refraction. You've got to treat off the manifest. If you can't get as much plus out as the cycloplegic, this is an 18-year-old +6, that you can only get to +4, and you can't release that last bit of plus, well, you can explain to them that eventually you're going to have to grow into that. Your eyes will eventually disaccommodate. But if you treat the +6, they're going to be -2. They can't switch off their accommodation, in other words. Yeah. So you can only ever treat your manifest. But it gives you that clue that you really need to push really hard if you're seeing a lot of latent hyperopia. So I'm going to take you through the protocol in the next slides. I'm kind of building up a bit of suspense as to how it all works. But this is the take-home message of what you're going to see throughout the protocol. We start with the undilated aberrometry. We monocular refract each eye to begin with. We tend to start with the right eye. You can start with anyone. And the aim of it is to initially push plus So you're going to push the sphere as much plus as you can get out of the system. We then refine the SIL axis. We then refine the SIL power. And again, we push out as much of the SIL power as we can. Not the most comfortable. It's the maximum that they can get to with the best visual acuity. Then we come back to the sphere again and we push plus again with a slightly different twist to the second time you're pushing plus. We do the second eye, and then we do what's called the binocular balance protocol. And this is something most people haven't heard of before, but we use it to help disaccommodate the eyes even further. So I'm going to take you through the protocol now, break it down into these different steps, and then I'm going to show you a video of Dan doing a refraction on one of our laser techs from the past, and I'll talk over that video and we'll kind of talk through it and you'll see it in action. Okay. So this is essentially the monocular portion of the manifest refraction protocol. We've got the beginning where we start with the undilated aberrometry. We're going to push plus as much as we can. We're then going to put up the 2040 line on the ETTRS chart. It's actually the 2050 line with the little O. And we're going to refine the SIL axis using the Jackson cross. We're then going to refine the power of the SIL. We then go back to the sphere and we push again the maximum amount of plus again that we can get to. And that'll be the end of the monocular refraction component. So let's break this down even into more detail. Firstly, the first step to determine the best sphere. So again, start with the undilated aberrometry, check the visual acuity, add an extra quarter, we're pushing plus, and we see if it blurs it. If it doesn't blur it, add more plus until you start to blur. If you do blur, remove the extra plus that you put in and see that they actually can read more letters. Now, that's an important point. They can read more letters. As we see on this side, sometimes people see a bit more contrast, but they can't actually read more. Okay. You're looking for the maximum plus in terms of visual acuity over here. So don't confuse the letters for looking larger as being better. And the second thing is when you push plus, you've got to give the eye a little bit of time to disaccommodate. All right? If you flick it in the lens, they often go, whoa, that's blurry. And you say, just give it a few more seconds. Can you still see that line? And, oh, yeah, hang on, there we go. I can start to make out the letters now. It becomes a little bit more comfortable. Then you push another quarter of plus, and they go, oh, yeah, that's blurry. And you take them back to the first plus that you pushed in, and they go, oh, yeah, that's much better. It's much. So you've disaccommodated already a little bit of that accommodation. Okay. The next step would be to look at the SIL axis and the power, and there you put up the Jackson cross, you refine the axis, and then you push as much of the SIL power as you can. Just remember that if you change 0.25 diopters of SIL, you want to go back at the end and just make sure you refine the axis again a little bit more. So if you actually end up adding more power to the SIL, then just go back and double check the axis because it'll be a little sharper for them. And then secondly, if there's no SIL to start with, then just put up the Jackson cross, put it at 180 and a 90, and ask them, which one looks rounder. And if it does look a little rounder, then put it at 45 and 135, and then just add a quarter and then see if you can refine it. You may still go back to 0, but it's worth checking, even if that one little tiny quarter is in place. And then the last step is to go back to the sphere again. So at this point, we're going to try and push plus a second time. We've given them a little bit more time to disaccommodate from the first little bit. But when you push plus the second time, you want to do this very slowly. So what I mean by that is physically slowly. When your finger's on the phoropter, this is why you can't do it with a trial frame. Because trial frame, you can't be switching lenses very. Phoropter, you can just dial it in. And you're almost blurring the eye because it goes in between the two lenses. And you give them a chance to relax, and then you click it in. And this process of just slowly trying to disaccommodate, you'll be amazed how much more plus you're going to get compared to your conventional refraction. And this is especially true in the younger patients, obviously, because they've got much stronger accommodator power. If you have a keratoconic eye or somebody with amblyopia, they might not perceive a 0.25 difference change, so you might have to go up in half diopter steps. Again, it's just something to bear in mind. In some cases, it's a bit more obvious. So again, does it blur them a little bit? It's important to give them a little bit of time to, this is the second half of pushing plus. Give them a little chance to disaccommodate. Give them a few more seconds to see if that vision does come back in, because the initial bringing the lens in place the extra 025 might be a bit blurry. And they go, okay, hang on, there, okay, actually it's settling in, I can actually see it now. We're looking for the maximum amount of plus and the maximum amount of SIL. Okay, so now we're going to talk about the binocular balance protocol. Now this is something foreign for most people. This is now, you've refracted each eye separately, and what we're trying to do now is simply see if they're still accommodating a little bit, and we're going to try and switch that off, inverted commas. So what you do is you're in the phoropter, and you just click in the two ret lenses in the phoropter. That's a +150 lens in the ret lens, and you click the ret lens in front of both eyes. So they're now fogged, effectively. And you ask them to look at the top line of the chart, 2200 line, and they can see it because it's not that foggy for them. And then you ask them how far down the chart they can read. And most people, if you're making them -150 by putting in a +150 lens in front of their eyes, can still read a 2063 line. If they can read better than 2063, they're underplussed. So if they're better than 2063, we just binocularly add in an extra quarter until you blur them up to the 2063 line. All right? They were accommodating the whole time. What you then do is you then compare the two eyes. Now, sorry, you can't do this. You can't do this technique for patients who are amblyopic, because this binocular balance, because you're going to do a comparison. So you've got them seeing the 2063 line, yeah? You've dialed in an extra bit of quarter of plus if you had to get them up to that level. You then take them back up to the top line of the chart, and you're going to ask them which eye is clearer. And you're going to alternate covering each eye. And if the eyes see the same, they're balanced. If one eye sees a little sharper than the other eye, then you add an extra quarter to the eye that sees better until they tell you that the eyes are now balanced. Okay? Because we're assuming they're still accommodating into that one eye. You then, once you've added these quarters in, remove the ret lens, if you've added a quarter, to make sure you haven't actually blurred them, that they can still see to the line that they could see. And if you have blurred them a bit, you've got to take it away. It's kind of a bit confusing, but you're going to see the video in a minute. It'll come together. So the point is that this whole section on binocular balance is all about trying to disaccommodate them binocularly now even further. And at the very end, once you've got them balanced, they're looking now at the smallest letters that they can. You can now binocularly again add in an extra quarter. And you ask and see if it blurs them. And you've got to give them a few seconds to let them disaccommodate further. And often you'll even get an extra quarter out of both eyes or even one eye. Okay. So you can see how this whole system is designed to get the maximum amount of plus, the maximum amount of disaccommodation for that patient, and the maximum amount of SIL. And you have a very hard endpoint. So if you're comparing apples and apples, it's very efficient. It's not just like somebody, oh, is this a comfortable prescription that you would wear your glasses with? Of course, you wouldn't want to wear glasses in these prescriptions. And actually, we tell that to patients. Sometimes, for example, you'll do a screening for a patient. They decide not to go ahead with surgery. And they'll say, can I have my prescriptions? And you know they're going to try and order a pair of glasses online. And you explain to them, I'll give you the prescription, but this is not a refraction for glasses. This is for refractive surgery. You're not going to find these comfortable. You should go and see your optician if you want to get a new pair of glasses. Okay. All right, so let's take a look at this. I'll talk a little bit over it, but Dan's going to talk through it a little bit as well.
We're going to just close the left eye.
So we're starting with monocular refraction. Pushing plus.
Or something N.
Does this blur them a little bit?
A little bit.
Not really? Does this blur them a little bit if I go to there?
Yes.
Yes. So you can see more letters if I go to here.
Yes.
More letters, so we took it away.
Two there, or about the same?
No, that's better.
So even sharper here?
Yes.
Okay.
Now we refine the SIL axis.
A few lines up where the arrow is. The edges are sharper with 1 or 2. 1 and 2, about the same?
Different, but yeah, neither is sharper than the other.
Okay. What about
SIL
3
power?
or 4? 3 and 4, same.
Maybe 4 just.
4, okay, and 5 or 6.
6.
And looking at the small ones, better 7 or 8.
8.
smallest you can see there?
SZRDN.
Okay, so the sill has now been refined for axis and power. Now we go back to pushing
Any more
plus
on that
again.
H line does it blur that H line if I go to there?
Look how slowly he
Yes.
brings it in.
It does. So any more on that H line if I go from 1 to 2? The same.
Yeah, it's the same really.
2, pretty much the same. Good.
Yeah.
Super.
All right.
Excellent.
So we weren't able to get an extra quarter, yeah, beyond the conventional refraction.
SZRDN,
Mhm.
H. That's about it really.
Mhm.
We repeat the same for the second eye, pushing plus to start.
Yeah, but
Still see it if I go to there?
no.
No. So it's better here.
Yeah.
Yeah. And between 1 and 2, the same?
No,
1?
two is
Slightly better on 2?
Yeah.
Okay. Looking at the O where the arrow is, the edges are
Refining the sill,
or 2?
axis,
2, the same.
Similar.
What about
and then the
3?
power,
Or 4?
4,
5? Or 6?
6.
5, 6 a little bit better. And looking at the small ones, better 1, or 2. 1, 2,
Similar.
2. If you had to choose. 1, 2,
1.
2. Slightly better on 1?
Yeah.
Okay.
okay. And then coming back to the sphere
How far down can you see there?
to push plus again.
H. Something. O.
Mm-hmm. Does it blur them a little bit if I go to there or not?
Look how
really?
slowly we bring in the quarter.
Yeah, a bit
A
more.
little bit.
Yeah.
More if I go to here.
Yeah.
So better here.
Yes.
And between 1 and 2?
2.
2 is a little bit better.
Yeah.
Okay, good.
All right.
Okay.
So that completes the manifest on both sides.
H. HC.
Now we're going to move into the binocular balance protocol.
Something. O.
Mhm, very good. Now I'm going to blur them.
So we bring the ret lens into both eyes.
The very top line.
Yep.
There's slightly different color, maybe. There's the blurry.
We see how far down the chart he can
Down
read.
You see just looking there. What's the smallest you can see there?
Okay, the ZK.
And that's the 2063 line.
Yeah.
If he could read better than that, we would dial in an extra quarter on both sides already.
Good. Okay, so it's 2060. Now look at the top line.
So back to the top line, and now we compare the two eyes.
Are sharper with the right eye or the left? Right.
The left.
Slightly better with the left.
Yeah.
So we add a quarter.
Right or left. Right. Left. Similar.
Pretty much the same.
Pretty much the same.
Now we check that the vision is still good because we've added a quarter to the left eye.
Yeah.
Does it blur them a little bit if I go to 2 there?
Binocular balance, yeah.
Not really.
What's the smallest you can see there?
H. HC. D. Something. O.
Mhm, good. So that line, any sharper here or the same? About the same.
About the same. Yeah.
Yeah, 2. About the same.
Yeah.
Blurs them a little bit here,
Yes.
so better there.
Yeah.
Okay, super.
Okay, so what you see over here in this example is we actually got an extra half a diopter of plus out of the left eye, yeah, over and above the normal monocular refraction of that left eye by using the balance technique. And it's just because you're just helping to disaccommodate by using the ret lens and fogging and giving them time to disaccommodate because they're trying to look through the plus, exactly. It relaxes the muscles. Okay. So just taking a step back again, the cycloplegic refraction is valuable. We use tropicamide because our patients are older, nobody's below the age of 18. And it doesn't last as long as cyclopentolate, obviously, 3 days. They're all going to have a dilated fundus exam, certainly in our clinic, so it makes sense to use tropicamide as the dilating agent so you can get the cycloplegic and you do it at the same time as your retinal exam. And again, the whole point of the cycloplegic is not that you're going to use it to treat from, but it just gives you a clue if there's any more latent hyperopia present in that patient's visual pathway. And then, of course, the surgeon has another go with their own refraction and disaccommodation attempts to see if they can bring out a little bit more of that plus. Remember that sometimes in the cyclo, not all the plus is real because of movements of the ciliary body when you dilate someone as well. So the surgeon comes along on their separate day, and they get a chance to look at all these different refractions from the optom visits, and they get to refract themselves, and it's the final refraction done by the surgeon that's used for the treatment, as I mentioned earlier. There are other important parts to the surgeon refraction being done on a separate day. This was just an example of a patient who was 9 years post-op, who had had a blepharoplasty recently, and was complaining that the vision felt it had changed. And the patient, you can see, came in and had some SIL. This is 9 years post-op. And so the optom thought, well, okay, we can put you forward for an enhancement. The patient wasn't living locally anyway, so went off and came back 6 months later to have the enhancement. But actually, when the surgeon saw the patient 6 months later, you could see the refraction had changed. And the patient actually was seeing much better. So we were a little bit confused which one is real, because no one's eyes change 9 years after laser eye surgery over a 6-month period, and why would they improve again? So the refraction was repeated a few days later, a week later, and you can see it was actually very consistent. So the truth is that this was just a case where the enhancement wasn't really required, but actually was due to epithelial warpage from the blepharoplasty itself. So just to say that there are a lot of influences on the refraction, and when you treat someone, you've got to treat them not just based on their refraction, what you see on the day, but you've got to also anticipate other factors that might influence the refraction itself. Okay, if somebody has a lot of dry eye, you refract a person first, and then you look at them on the slit lamp. So if you see a lot of SBK from exposure dry eye, that might not be the real refraction. It's a clue that you have to come back and actually repeat the initial screening again. And then just to finish off, I just want to talk about a very strange concept, which, again, not everyone is aware of, but it's something that it actually helps us for looking at outliers. And that is comparing the manifest cylinder, so this is your astigmatism, the amount of astigmatism, to the corneal astigmatism. So this concept is known as ocular residual astigmatism, or abbreviated as ORA. And really what it is just subtracting the one from the other. So effectively, you're taking your manifest SIL power and you're subtracting it from the corneal SIL from your topography. If you have a high level of ORA, a high level of ocular residual astigmatism, it's more likely that you have not done a very good job in your refraction, in pushing SIL. This is what it's telling you, most likely. It could also be, though, that your topography wasn't done very well, that you haven't got a good quality topography scan. The point is that most people don't have a lot of astigmatism at the level of the lens. Most of it's at the level of the cornea. So just take this example. This is a really good example which highlights a good case of ORA. This is a -850 patient, and the optom refracted the patient, could only push out a quarter diopter of astigmatism. The surgeon, on a separate day, refracted the patient and also only found a quarter diopter of astigmatism. But if you look carefully, the aberrometer actually found almost 0.75 diopters of astigmatism. So it found a bit more. But we weren't able to get this out of the refraction. This is two different people on 2 different days. Pushing SIL couldn't bring it out. The patient didn't accept it. If you look at the corneal astigmatism for this patient, it was at 1.5 diopters. So again, in this case, we're saying it's got to be internal, right? That's where it's coming from, to counteract this. But if you look at the inside of the cornea, because the ORA is 1.31, if you look at the inside of the cornea, the posterior curvature of the cornea is only half a diopter of astigmatism present there. So therefore, the rest of it must be at the level of the lens, and it must be neutralizing this corneal astigmatism because it's not coming out in the manifest refraction, right? Makes sense. Well, here's the 1-year post-op result. The patient had 1 diopter of astigmatism left behind. We didn't treat it. And if you look at the cornea, there it is. So in this case, it was most likely that in our manifest refraction, we still weren't able to push the little bit of SIL out of that eye. Patient just didn't tolerate it. But you've always got to treat on your manifest refraction. You have no choice. So the point we're making here is that if you find a high level of ORA, ocular residual astigmatism, the first thing you should do is go look at your keratometry. The second thing you should do is re-refract the patient on a different day, maybe even twice. And if you've still got a discrepancy, you've got to educate that patient that, yeah, you probably have a slightly higher chance of needing an enhancement. Yeah, because you have the slight discrepancy. But I can only treat with my manifest. That's what's reliable in my hands. Okay. And there is a little bit of debate on this. Some people say go halfway when you treat and things like that. But our philosophy is still to treat using what you find on the manifest. It's just that you can match the patient's expectations a little better based on their anatomy and what you're able to elicit from the refraction. Okay. And to help you with this, it's on your handout. It's in your little doofy, your memory stick. I call them doofies in the practice. Tim has actually created a nice little calculator for all of you, where you can actually just put in the sphere and sill and the axis and the keratometry, and it will tell you what the ORA is for that patient. So it's a nice way of being able to check this in the background. Very, very nice and simple. Okay. All right, so we're not saying that this is the best refraction technique in the world, although we are. It is published. It's available for anyone in the world to use. And the key message about this is that this is not for glasses, it's not for contact lenses, this is for refractive surgery. And the second part is that if you do adopt this, which I encourage all of you to, every single person in your practice has to adopt this technique as well. It has to be completely, 100% taken on board by everybody. And what you'll find is that very quickly over time, you'll get better accuracy out of your nomogram, and you'll get fewer outliers and fewer scatter in your results as well. Okay. We'll just take one or two questions before lunch, quickly.
So if you have, let's say, like you find plus 0.75 more on cycloplegic than manifest, what becomes your endpoint for what to treat when you're rechecking that? Let's say you put the cyclo in front of them, they've lost a line, one click less, they read a line but not well, another one less, it's easy, they read it quick. How do you pick what you're treating there?
So again, it's exactly the same thing. Can you read more letters, or is it a little bit more comfortable? You want more letters. That's when you would disaccommodate them by that extra quarter.
Okay.
But you will hit a lot of people have latent hyperopia. You cannot get this accommodation to switch off. It's just not possible to get all of it off. And again, you can educate them. We do. We say in a young patient who's +4, and then I do a cycloplegic and they're +6, I might get another half out of them at my refraction because I'm now aware of this, it's there, and I know I really have to push them. But I'm going to tell them, in 5 years' time, you're going to be +1. You're getting older, your muscles will relax a lot more, and it's there. I know it's there. And that's part of the discussion with them. Yeah.
So you're picking the most plus where they're still reading their best corrected line.
Correct, yes, yeah. Second question.
In some cases, we find that manifest refraction is in different axes than the topography or keratometry. So always we follow the manifest.
You always treat of your manifest refraction. That is what you trust. Again, if you see something different on topography and stuff, you can go and double check it. So it's interesting. Sometimes I have a patient who's not seeing very well, and I do an aberrometer on them. And I just take the aberrometry, which often looks way different to what I would expect, and I shove it in the phoropter to the nearest quarter, and they see much better. And I'm like, whoa, I just got taken right down the garden path by this patient into a rabbit hole. Yeah, they just accepted, and yeah, that looks good, and that's nice, and everything, and I was way off target. So it can happen like that, but more times than not, it doesn't. Yeah, obviously, because you're actually refining things as you go along, yeah. Sorry?
Always going for manifest.
Always your manifest. You only treat off your manifest. But if it doesn't look right or something's not right, it gives you clues to double check. Yeah, sure. And if you're really not sure, bring them back another day and double check it again. Yeah.
You mentioned an electronic phoropter is not good for this technique. What
No,
was the reason?
because the problem with the electronic phoropter is that it just shoots the lens in. So they don't get that chance to disaccommodate. We bring that on the second time of pushing plus, you should bring the lens in very slowly. Those of you who are going to spend a time with our optoms on Sunday morning, they'll go through the technique and you'll see it in real terms. You bring it in quite nice and slowly so that you give them the eye like a second or two to disaccommodate as it blocks the view as the next lens comes in. But generally with an electronic phoropter, they just shoot in. And then of course they won't like that because they're not going to disaccommodate any further. Yeah.
Thank you.
Yeah. Yeah. Okay, just a couple more questions and we'll break for lunch.
How about doing a street retinoscopy to see the maximum refractive error before we move on to the manifest refraction?
No, we never really do that. We just use the aberrometers. They're so much more accurate than playing with yeah. We just never do that anymore, yeah. Yeah.
Disadvantages of using a trial frame because we have the electric one or the trial frame.
So a trial frame is exactly the same problem as the electronic phoropter. You can't subtly bring things in and out. Okay. It's too quick, the movements, and it's disjointed with one and then the other and things for the binocular balance and things like that. So you really have to have a phoropter for this technique. It only really works with a phoropter. The only time we ever use a trial frame is after surgery, if someone needs an enhancement, and we just want to show them the difference of like a half adapter could make in the real world, because they're sitting in your chair. Yeah, you put a half adapter in the trial frame, give it to them and let them walk around in the passage and things like that. And they go, wow, yeah, that's so much more comfortable. Okay, fine. In the real, rather than just sitting in your chair looking at a chart, they can see it in the real world. Yeah. Yeah.
Thank you.
Okay, one more question.
Especially for the patients with, well, I've seen many patients with very high hyperopy, and they have very big accommodation span.
Sure.
And because you say you treat what is manifest, and I find it like the feature of a failure. I know. Is it possible before planning the surgery to make treatment, to relax because I don't know, what if I have 8 dioptries and manifest is only 4 or 5?
Yeah,
anyway,
but again,
in 3 or 4 years,
sure,
I will have the patient back.
Yeah, it's good. You can charge them again for another enhancement. I'm joking.
But no,
because somebody's natural accommodative state is their natural accommodative state. You can relax people. You can give them, what would you give them? Stronger glasses to relax them?
Yeah, I have a treatment for my patients of LASIK with hyperopy.
So if you can get them
I prepare my patients like 1 month.
If you can get them consistently pre-op to accept more plus in glasses, sure, you could do that. There's no issue with that. But we're just simply saying that using this technique, you will find a lot more of that plus than you would normally find from a conventional refraction technique. Okay. This is the point. You almost always will find much more correlation, much closer to what the cycloplegic refraction will get you. And the second point is you can't switch off that accommodation. If you've got somebody who's just a really strong accommodator, that's what they have. So you treat the manifest and you explain to them you will need an enhancement. But we're all going to need enhancements. I've had an enhancement once in my life, and I'm going to need another one soon because I'm getting a bit older.
And if I need to repeat the refraction, it has to be the same optometrist or?
No, it can be anybody because they're all using the same technique. Yeah. Okay. Sorry, I can't hear you. Well, okay. Were you here yesterday? Were you here yesterday? Okay, so you listened to the lecture.